which are available to us. So in the next few minutes, what I'm going to do is some background information and some discussion about this topic, and then we can involve our national panelists today, and we can have some fruitful discussion about this subject. So what I'm going to do and outline in my presentation is to tell you something about post-COVID lung fibrosis, which is a reality which we are seeing now. What is the role of anti-fibrotic therapy in this post-COVID ILD that we are seeing? We'll have a brief overview of nintedanib. We'll compare it with pirfenidone. We'll summarize the learnings that we have done in this talk, and we'll begin some question and answer session with our dear panelists. So post-COVID lung fibrosis, or the short form PCILD, which has been given to it, is a reality, and there is a small portion of severe COVID-19 cases with acute respiratory distress syndrome who continue to remain hypoxemic despite giving adequate treatment to them. So these are the patients who have had severe COVID illness. They have gone for oxygen support, and then even if oxygen support does not suffice, then they go on to receive the high flow nasal oxygen therapy or non-invasive ventilator, depending on increased work of breathing is there or not. And maybe some of them go to also invasive mechanical ventilation. Some of them recover. Most of them who have gone to mechanical ventilation usually succumb. That is our experience. But if we see the chest imaging of this subset of patients, we see that there is a fibrotic changes seen in the form of traction, bronchiectasis, architectural distortion, and septal thickening, which is similar to the changes which we see in other fibrotic lung diseases like IPF or systemic sclerosis or progressive fibrosis ILD. The previous corona outbreaks, and we have learned from the previous viral outbreak of the same virus, that SARS and MARS have been associated with substantial post-viral fibrosis and any viral disease. For example, we know that post-viral fibrosis does happen in some of the patients, and we do see the physiological impairment as its objective assessment of this fibrosis. So what the available data indicate is that about 40% of patients with severe COVID-19 develop ARDS, and 20% of these ARDS cases are very severe. They require oxygen support, invasive mechanical ventilation, non-invasive ventilation, high flow oxygen, high concentration oxygen therapy. And hence, we need to really see that the prevalence of post-COVID-19 fibrosis becomes apparent in time because of the large magnitude of people affected by this COVID pandemic. So, although, and it is true that many patients who develop ARDS survive the acute phase that we see of the illness, a substantial portion die as a result of progressive pulmonary fibrosis. So most of them, they would succumb, in fact, and that is the problem. And these are the severe COVID illness patients. Importantly, what we find in an autopsy study of 159 patients with ARDS, which was published way back, we see that fibrosis was noted in about 4% of this patient within 1 week, while 24% of these patients had a disease duration between 1 to 3 weeks, and 61% of them had a disease duration more than 3 weeks, which suggests that to be effective, any potential anti-fibrotic intervention should be considered within the first week of ARDS onset. This is a lesson learned from this study. We know that ARDS actually settles by fibrosis and is seen in any post-viral illness, and there is a potentiality of this fibrosis which is there in these conditions. And this paper, this paper which was published in Lung India really focused our attention on this population, and it predicted that the tsunami will follow the earthquake of pandemic, and we will have substantial burden of this post-COVID lung fibrosis, the fibrosis which has been initiated by this COVID illness. And we have array of media reports which suggest that even the transplant was done in these patients and there was substantial burden which lead to basically patients being transplanted lung, although these subsets are very small in the world. But still, we have got some insights from these lung transplants, and I have got some data to share from my transplant pulmonologist friend, Dr. Apar Jindal, who shared this with us. And you see the explants that were taken out of this COVID patient. So this is from COVID transplant patient in whom lung transplantation was done, and see the lung affected by the lung. And when we had a conversation, he said that this is just like a leather ball, and the lung really becomes hard, and you literally have to really do a lot of effort to cut this section, and it's really hard. So this picture really shows that how badly the COVID can affect the lung and how we should really intervene early to save these patients who are eventually going to die.
Hello. Yeah, there is some technical issue. We'll just get back. Dr. Swarnakar, are you there, sir?
Yes, I'll start from the, so can I share my screen?
Yes, yes, sir. Please.
Do a lot of effort to cut this section, and it's really hard. So this picture really shows that how badly the COVID can affect the lung and how we should really intervene early to save these patients who are eventually going to die. So when we see this explant slides which was shared, we see that this becomes early and this process starts early. First, there is a cytopathic changes with viral inclusions that we can see in the tissue, which triggers the illness, causes its progression. We see this enlarged pneumocyte nuclei within this viral cytopathic changes. I'll start from the, so can I share my screen?
Yes, yes, please.
Do a lot of effort to cut this section, and it's really hard. So this picture really shows that how badly the COVID can affect the lung and how we should really intervene early to save these patients who are eventually going to die. So when we see this explant slides which was shared, we see that this becomes early and this process starts early.
Hello, not able to hear audio.
Right, sir. Right, sir. Right, sir. Just give us a second. Vaishnavi, you are there? Just wait for a couple of minutes. We'll get it started.
Early, first there is a cytopathic changes with viral inclusions that we can see in the tissue, which triggers the illness, causes its progression. We see this enlarged pneumocyte nuclei within this viral cytopathic changes that we see in the lung. We see the giant cell infiltration, which really triggers the inflammation in the lung. We see widespread congestion throughout the lung, which we see the alveolar being actually flooded with the exudate and also the blood. We see focuses of abscess with acute inflammation, with potentially that this inflammation will heal by fibrosis and will damage the alveoli, which is really seen in this condition. Then this gets into organizing pneumonia, and we got organized alveolar damage, and the fibrosis actually sets in. These are actually the slides from that lung transplanted patient, and we see really good evidence of fibrosis progressing in this viral pneumonia, the COVID pneumonia, which progresses into organizing pneumonia and may settle with a bit of fibrosis left. This is a whole slide section with patchy fibrosis and congestion that we can see throughout the lung, and this affects the whole lung, and it is quite progressive, and it's very difficult once it happens to really prevent it. And we should do all the means which are available to really intervene early, so that this, of course, doesn't happen. This is what we call Mason trachome stain, which we use to see the fibrosis in various organs, and we see the interstitial fibrosis in lung in these patients, very beautifully demonstrated by this Mason trachome stain. So this is a reality, and not even the fibrosis, but added problem in COVID-19 pneumonia is a capillary thrombosis, not even in the small, and it affects not only the small capillaries, but we see the thrombosis also in the large vessels. So it's really a very unique disease, which actually causes the virus to come and also multiply, have some even also dysregulation causing cytokine storm. It is also a thrombogenesis disease, causes widespread inflammation, and there's potentially that all these things basically actually settles into fibrosis for the long term. So there is a potentiality of this pulmonary fibrosis happening secondary to COVID-19, because once the virus enters the body, it of course gets attached to this very important ACE2 inhibitors, ACE2 receptors in the lung, and then it just multiplies like virus. Virus replication happens very fast, and during this time, some of them may progress to immune dysregulation, which causes release of fibrogenic material like cytokines, T cells, which really damage the lung and causes alveolar capillary damage. This of course leads to lung fibrosis. So this is a process that is quite there in this COVID-19 pneumonia and is the potential cause of fibrosis in some patients. Mind you, not all will have this. It's only some subset of patients which we will see will eventually go in for actually fibrosis. So there is a cytokine overexpression in COVID-19 patient which causes fibrosis. And when damage occurs in the lung, the tissue, a set of growth factors in cytokine, including like MCP1, TGF1, TNF alpha, beta, IL-1B, IL-6 are overexpressed and released by the cells. And the recent reports show that the serum levels of this aforementioned cytokine do seem to be increased in the serum when we measure it. And the growth factors are also highly increased in COVID-19 patients. So there is a cytokine overexpression in the fibrosis. There is a higher cytokine level in COVID-19 patients. And we had seen such cytokine levels increase in even previous SARS and MERS disease, which happened before this COVID. So when we come to the radiological features, we see some evidence of this fibrosis when we do a CT scan of this patients, and you can see one or more of features like interstitial thickening. You can see a bronchogram. You can see irregular interface of tissue and air within that actually set of lung imaging. We see traction bronchiolitis and traction bronchiectasis. We see in some patient coarse reticular pattern happening, and also septal thickening happening quite early. We see parenchymal bands, reticulations, sometimes pleural effusion and they have organizing pneumonia, and if it doesn't settle, then of course we have a fibrosis, a non-specific interstitial pneumonia like picture, and we have diffuse alveolar damage, and eventually in some patients we can have honeycomb pattern, as you can see in this photos. uh, uh, we have to really act early because this pulmonary fibrosis may develop early after hospital discharge. So it's seen in the study as 40% of the patient had, and older the patient with severe illness, they are more prone to develop this fibrosis. And it is even seen in mild cases. Imaging finding in COVID-19 is of course quite milder if we compare to other viral illness. But the problem is that magnitude of people who are affected by it really makes us to think, if we can say this large chunk, although it is quite a minority cases in total cases, but still that will amount to huge burden. And if we can do something about it quite early. So these are the PCILD features which you can see in the lung, and as I have just described, you can see the septal thickening, the ground glass opacification, which eventually goes to actually consolidation and an organizing pneumonia and eventually fibrosis. So these are the features that you can look for when you are suspecting that these patients may progress to fibrosis and can actually intervene quite early. So this is a case report in Lung India, which was of a 75-year-old female with no history of lung disease, and she developed severe pulmonary fibrosis within 1 month of acute severe COVID-19 pneumonia, had all the features of fibrosis like of course Krebs. She needed hypoxia. She had hypoxia and needed home oxidation, and her CT in fact show that it evolved from ground glass opacity to organizing pneumonia to honeycombing and traction bronchiectasis. And these changes happen despite this patient being given, of course, steroids. So we need to think whether we have to combine this anti-inflammatory therapy with some anti-fibrotic therapy at that point of time to prevent this fibrosis to happen. So the postulated mechanism for development of post-COVID fibrosis has been defined. There is a upregulation of cytokines like the TGF beta, and there is increased production of angiotensin 2. There is a down of regulation of ACE2, ACE2 receptors in the lung, and which eventually causes myofibroblast activation and extracellular matrix accumulation in the tissue, leading to lung fibrosis. And this process is all compounded if suppose patient is having hypoxia, which is refractory. So we keep on increasing the oxygen level to 10, 15 liters, and if it doesn't help, then we put this patient on high flow, high concentration oxygen, leading them to be prone for hyperoxia effects of free oxygen radicals, which can again actually damage the tissue. Some of them go into this what we call mechanical ventilation, and there is a factor overlay of ventilator associated lung injury, which eventually can end up in lung fibrosis. There is a potential multiple mechanism in how this COVID-19 patients can eventually develop lung fibrosis. Now, this post-COVID lung fibrosis can follow any of these three courses. So let me tell you that most of them will resolve spontaneously over time. So these patients, most of them, as we are seeing, they come after 3 to 4 months. And even if they have got CT scoring high, they may have a resolution. But some of them have got, they would remain static. They will still show all those features. And few of them, very few of them will progress, will have progressive fibrosis over time. So we know that most of them will improve, but we don't know which patient will improve, which patient will have static, and which of these patients will eventually progress to the fibrosis which is going to remain. There is no way that we can find out, and hence we need to do something at appropriate time to prevent this. If we can't predict the course of this fibrosis that would take in these patients. So this is the early report which came from China that we need to really have a long-term follow-up to determine whether this reticulation which represents is an irreversible fibrosis, but that may require time. It may happen that this may require over the time, maybe years to see, but at least what to do. Shall we just wait, or we can intervene to do with whatever drugs are available and to see the, of course, risk and benefit, of course, ratio of these agents and see if we can apply and, of course, prevent some of these very few fibrosis that can happen. So what are the predictors of post-COVID ILD and fibrosis? As you know that this happens even in IPF, that the advanced age patient, the patient who are aged are more prone for fibrosis if he has got severe COVID illness, as they may require high oxygen concentration, they may have undergone cytokine storm, and hence they've got immunosuppressive dysregulation. These patients are on NIV, high concentration oxygen, and hence they may be prone. The prolonged ICU, and these patients eventually have a prolonged ICU and hospital stay. They may go for also mechanical ventilation. Some of these patients who have got history of smoking or underlying lung disease are more prone for this fibrosis and chronic alcoholism. So these are the risk factors, and you can identify these patients and see if these patients can be prevented from going to fibrosis if you see some changes and some raised biomarkers and some relevant biomarkers like CRP and IL-6 being raised in these patients, and this can be identified and treated early. So there is a burden of fibrotic lung disease following COVID infection, because as of now we have got around 8 crores of people worldwide affected with COVID. About 1 crore people have about 16 lakhs people have died. In India itself, we have got a disease burden of about 1 crore, out of which 1.5 lakh people have died, and hence also we could have a large burden of these COVID-19 fibrosis patient. Hence, there is a therapeutic rationale for the use of licensed antifibrotic, of course, therapy repurposed to be used in these patients, because they've been used in acute exacerbation of IPF, they've been shown to have its effect, and including those triggered by viral infection, fibrosis. We know that they can be used and they've got potential to be effective in this condition too. So available antifibrotic therapies might have a role in attenuating profibrotic pathways that COVID infection takes in some of the patients and lead to fibrosis. So what we see is that the pulmonary fibrosis has in COVID-19 has got potential to be treated by this available antifibrotic drug, because it has onset of antifibrotic effect is quite early. There is a protection against exacerbation, as is seen in internative studies, and they have a broad spectrum benefits of antifibrotics. So they have got action against various mediators of fibrosis that are actually generated in COVID-19. We have seen that actually pirfenidone inhibits experimental acute lung injury, which happens in these viral illnesses, while both nintedanib and pirfenidone inhibits IL-1 or IL-1 effects on pro-fibrogenetic pathways, and they also inhibits IL-6, which is again another factor for this fibrosis happening in these patients. So we have to see that this fibrosis, which happens in in other illnesses like IPF and in progressive fibrosis of ILD, nintedanib has been quite useful, and we can extrapolate its use in also treating the potential fibrotic pathways which happens in COVID-19, which happens due to immune dysregulation, because these pathways in COVID have got some similarities to those pathways of indication in which nintedanib is used and has been authorized to be used. So what happens is that all these patients have got acute COVID-19 pneumonia who fall sick or who require oxygenation. During their pathways to evolution to COVID-19 pneumonia, they may suffer severe pneumonia, they may have a superadded bacterial infection, there is a microvascular damage, these patients are sick, and hence they may be put on mechanical ventilation or high flow oxygenation or non-invasive ventilation, requiring high oxygen therapy. Then we have inducer susceptible, like I just mentioned, that who are people who are with comorbid conditions, who are aged, are more prone, those who are smokers, and air pollution is a factor which increases during this time. Can also have some relation of these patients developing into going to fibrosis, and we do see, because now people are coming after 2 to 3 months, and we do see in some of the patients, we see impaired gas diffusion as measured in DLCO. We are seeing restricted abnormalities in, of course, lung function test when we do it. We do see that it also decreased exercise capacity when we do a 6-minute walk test. and their overall quality of life is of course decreased. They just may be more, they just may be still dependent on oxygen therapy. And we don't know, and we are getting some patients who have been treated, who have been discharged on oxygen therapy, even that oxygen therapy has been also been weaned off, or has been less, but still they come and they have some acute illness following this COVID 2 to 3 months afterwards, and some of them have died, as is our anecdotal experience, as all of you may be having. So what we do for this acute COVID-19 pneumonia is to give a therapy which is hit hard and hit hard and hit early. So we advocate a very early antiviral therapy. If suppose patient of course, requires oxygenation and he goes into for this COVID pneumonia, which is seen in a chest in the chest, we also initiate anti-inflammatory therapy or steroids. Now, can we also add this anti-fibrotic therapy to this anti-inflammatory therapy in this subset of cohort of patients whom I have just described, and we can follow up these patients and rehabilitate them so that they can survive this fibrosis and this fibrosis can be prevented? Can we do that? That is the one hypothesis, that is the one postulation, that is the one posit that we all should think about. The evidence is there. We have to really think in terms of long-term follow-up of these patients. And now, if we are convinced that okay, we can help these patients, so which drug to be used? So we will just have an assessment of nintedanib. You know this molecule is available since about 3 to 4 years in the market and has been used in various IPFs. So nintedanib binds intracellularly. It is a tyrosine kinase inhibitor, and it binds intracellularly to key receptors. They block and downstream the signaling cascades. So that nintedanib has a proven mechanism of action and has been shown to inhibit the fibroblast proliferation, the migration, and fibroblast to myofibroblast transformation, which is required for fibrosis. So it and also it blocks the downstream signaling. And because of its very good effects, IPF has approval from US FDA to be used in treatment of IPF, SSC, ILD, and nintedanib has been used also now in what we call progressive fibrosis ILD. So there were 3 indications to treat, and this is all we know about nintedanib, that it is really useful in these fibrotic conditions. So if you compare nintedanib versus pirfenidone, the another anti-fibrotic drug which is available in inhibiting the pathways involving pathogenesis of fibrosis, we find that nintedanib inhibits proliferation and migration of fibroblast, myofibroblast, with a reduction in the synthesis and deposition of extracellular matrix in the lung, eventually preventing pulmonary fibrosis. So there are trials which are happening. Trials take their own time, maybe because these are the conditions which are chronic. Maybe these trials will be there for about 3 to 6 months. We don't know. Some of the trials with nintedanib are going on. They are comparing it with placebo. They're in phase 2 or phase 3 trial, and there are some novel antifibrotic agents too which are being tried. And we are still awaiting the result, and may take some more time for these to come and to have really a solid evidence. But by that time, we can try using this in the subset cohort, carefully selected patients. So if you compare nintedanib versus pirfenidone in ILDs, we see that nintedanib has a wider approved indication of its use, which has been given by US FDA to be used in idiopathic pulmonary fibrosis and systemic sclerosis associated interstitial lung diseases, and also progressive fibrosis in interstitial lung diseases. And these agents have been typically studied for longer period of time. So usually the measurements are done every 3 months, 6 months, and of course we see in pirfenidone trials. But in nintedanib, we have seen that there is an early separation of prevention of FVC decline curves as early as just 4 to 6 weeks, and hence we can deduce that nintedanib has got a faster onset of action and may be used, and because of its use in acute exacerbation, it's also useful, as has been demonstrated in these trials, in acute exacerbation of IPF, and hence may score over to be used in COVID fibrosis. Then of course pirfenidone, and of course pirfenidone has got some mortality benefit, which is not even intended, which has not been proved, but it improves survival, it improves quality of life, and the inbuilt trial demonstrated efficacy and safety of nintedanib across various autoimmune and also CTD ILDs. We have establishment of long-term safety and efficacy. We cover this. We got a very comparable tolerability profile of nintedanib, and unlike pirfenidone, there is no need to up titrate. So the dose of pirfenidone required for achieving this antifibrotic effect is 2,400 mg, and we cannot escalate the dose over time. It takes a bit of time to really upregulate this dose. While in, of course, nintedanib, there is no need to titrate. We can optimize the dose. We can start the dose, the full dose required for achieving its effect to prevent fibrosis can be done from 1 day daily recommended dose, as you know, is 150 or 100 mg of twice a day. It can be started from day one, unlike pirfenidone, which takes 2 to 4 weeks to reach recommended daily dose of 2,403 mg, and may escape this window to treat this patient to prevent fibrosis. Plus, there is a less pill burden. Of course, we do have some tablets which are now coming of higher dose in also pirfenidone, but still it is much more than the twice daily dose of the nintedanib, which leads to better adherence if you got a less pill burden in these patients. So what are the key messages that we would like to give is that COVID-19 leads to a wide spectrum of respiratory diseases with extremely high incidence of acute respiratory distress syndrome. So the risk factors for severe COVID-19 are shared with idiopathic pulmonary fibrosis, suggesting that this group of patients will be at increased risk of severe COVID-19. The burden of fibrotic lung disease following COVID-19 infection is likely to be high. Therefore, given the scale of the pandemic, the global burden of fibrotic lung disease will probably increase considerably as the time comes, and we will see there is a therapeutic rationale for the use of licensed anti-fibrotic therapy in acute exacerbation of IPF, including those triggered by viral infection like COVID. Available antifibrotic therapies have shown to be broad antifibrotic activity regardless of its etiology, and these drugs might have a role in attenuating the pro-fibrotic pathways which takes place in COVID-19 infection. The novel antifibrotic strategies have a range of antiviral and epithelial protective effects in models of acute and also viral-induced lung injury, as has been seen in various studies. The previous coronavirus outbreaks have been associated with substantial post-viral fibrosis and physiological impairment, and close follow-up of this patient after COVID-19 is essential. We may have to follow up them for years together to really see the effect on how they behave, and hence there is an urgent need for therapies that mitigate severe COVID-19, and clinical trials of anti-fibrotic molecules should be considered. They are being done, their results will come, but meanwhile, can we really use them early to prevent this fibrosis? And then maybe we'll be wiser or not, we'll be told by this outcome of this clinical trials which are happening. So as of now, the potential COVID-19 patients who may get benefited with this nintedanib are patients who have unexplained or disproportionate hypoxia despite giving all the therapies. They still are hooked to oxygen. The patient and these patients require prolonged ventilation requirement with high concentration of oxygen, which itself can damage, of course, the tissue. The patients who have got severe RDS, when you see the HRCT evidence of fibrosis after you're seeing ground glass opacification, organizing pneumonia, and now it is progressing to some evidence as seen in HRCT of also fibrosis, and patients who are continue to be hypoxic post-discharge for prolonged period and also require oxygen therapy, maybe for a prolonged period of time. They may be the patients who are having this fibrosis, which can be done, and they can be followed up with HRCT to show whether there is a progression of fibrosis or not. So this is a little background of the things which are there, evidence-based up till now, and we will have illustrious panel discussion after the show. But that's all from me. Thank you, and thank you for your patient listening. Hello, thank you, and welcome panelists, all of you who are there to answer and be able to fetch a background of this use. And you all have seen COVID everywhere, in fact, from the beginning of the pandemic. So we have some questions which we will actually ask you, and just to have a better idea And to just begin with, if I can ask, and if I can start from Dr. Nitin, because I think Pune started earlier than Nagpur. We had this peak in Nagpur only in September, while Pune was worst affected. So, what is the proportion of this COVID patients in your actual practice developed post-COVID fibrosis now that you may be having 3 or 4 months of follow-up in these, of course, patient Dr. Nitin, and then I'll go to Dr. Ashish and Dr. Satish.
I think if you really look at the total size of people who got infected in Pune, I think you would dare say that more than 50% of the population as such is covered with COVID. But from the point of view of people admitted, that is a much smaller number. Then the number of people who went on oxygen, that is even a smaller number. Then the number of people who required high flow oxygen therapy and non-invasive or invasive ventilation, much smaller number, and the deaths even further smaller. So if you really keep on seeing the entire COVID scenario, it's a very, very, very small portion of it which is being affected by the possible post-COVID sequelae. You may call it fibrosis, you may call it regressing fibrosis, you may call it self-resolving fibrosis, or whatever terminology eventually may mature for it. Right now, as I see it, it seems to be a disease which settles by itself. If you have to look at the figures, I don't think I have a data of how many in the entire Pune city, but I can tell you from my practice, and I was sharing with Dr. Tandon also, he sees 1 or 2 cases per day. In my practice of around 30 patients that I am seeing now in the post-COVID scenario, the practice has come down to nearly 50% of what it used to be. So in those around 30 patients, around 4 to 5 patients have post-COVID sequelae. So that sort of speaks. But of course, this is a biased sample, and the biased samples come from a person who is doing pulmonology and nothing else. I'm sure these numbers will be, say, 1 in a general physician's clinic and so on and so forth. So I think we have to imagine that small, but an important and relevant number. I wouldn't look at this as a huge number, but it will be still, if you really look across the country, you will find a few thousand people who are right now suffering from this problem. And mostly they are not being treated by pulmonologists for all practical purposes. Many of them are only treated by physicians. I think the first order of business may be to bring them back to the pulmonologist, because the understanding of antifibrotics and whatever else we are doing is limited when it comes to non-pulmonologists. That's number one. And the second part of it is, even pulmonologists have to stop fighting, and come to terms with the idea that what are we really dealing with and how are we going to tackle it. Because I see huge amount of to and fro kind of discussion even on various chat groups that we have. Some people say, oh, there is no fibrosis at all whatsoever. And some people say it's all inflammation. So I think we first have to come to terms with the clinical terminology that we are using, what we are going to call it, and how are we going to approach it. In fact, Rajesh, with your abilities, an early consensus statement is the best you can get on from ICS or a body like that, because I think that's relevant, because we are not defining our disease also properly.
Yeah, and Nitin, this week we have been also there. If you see H1N1, which was there early, and then we have seen some of the patients who got the sequelae. So sequelae do happen, although it's now a very small percentage of.
See, I think the people have just taken two extreme sides. There are people who are saying everybody on day 1 should be an antifibrotic, which doesn't make sense to me at all. I mean, just is not sensible. But at the same time, there are people who are saying there is no fibrosis at all. And what are you talking about? There is no fibrosis. At the end of 3 weeks, the world is back to normal. Those who are dead. Those who are alive. I mean, that also doesn't seem correct.
I think we have to find a common ground. Yeah, we have to find a common ground.
There must be a common minimum program with the pulmonologist at least, if not anybody else.
And Dr. Satish, what's your point of view from the South region?
Okay, good afternoon, everyone, and Rajesh for that excellent view. And I agree with Nitin that we don't have any patients with lung fibrosis, even though the media tried to highlight or sensationalize, saying that there are a lot of fibrosis going on. So the patients are aware of it, and patients keep asking us about, is there a fibrosis or is there a chance of fibrosis? And number two, is what Nitin mentioned was that, this is the purview of pulmonologists. I agree with him. And in fact, one of the professor, a famous professor from US, in his concluding mark said, after the treatment is over and patients who are left with the sequelae, should be treated or must be treated by pulmonologists. He used the term smart pulmonologists will take over and then, deal with this thing, because we know how to do the lung function, we know how to interpret them, we know even if it is not there, what may be,
Yes, I'll
required.
just come to that.
And of course, we always do, the reviews with our radiology colleagues, and then take the, the videos and CDs and scans and show them, and then, dissect it out nicely. Is there a fibrosis? Is there traction bronchiectasis? Do you think there is a septal thickening? We always go and discuss with them, and we are used to seeing them. So appropriately, I think, we should all be treating lung fibrosis. As Nitin said, it's an important thing, because many are, treating physicians, and I don't blame them in a pandemic. Everyone should be doing, because I'm seeing 200 milligram perfenadine, twice a day,
Yeah.
take it, along with, some steroids, and then never, it is increased. So they don't know when to, increase it. It's as you mentioned, summarized it. It has to be upfront. It is not like idiopathic lung fibrosis where you have to go on increasing one tablet every third day or a week. And the terminology, of course, as Nitin said, I call it as post-COVID sequelae. I don't call it fibrosis. I don't call it as the progressive or non-progressive, reversible, irreversible, and there are a lot of lessons that have to be learned from seeing the data. In fact, the Austrian data showed that at the end of 3 months, almost 30-40% of them had no residual effects which were there in many patients initially. We are also seeing that we don't know what is really working, and if you put them on antifibrotics, and there may be a tapering steroids. I taper steroids quickly, as we all know, and learned that there are a lot of side effects and infections, tuberculosis, and mucor, and so
Yes.
on, and causing diabetes. So antifibrotics,
Yes, we'll also come to that question, that who are the population who are at risk. So Ashish, what is your experience in Allahabad? How has been COVID affected, and then how much you are seeing this post-COVID, what we call sequelae, as of Dr. Satish has also rightly put it. So how many of your practice who are just coming as a follow-up of COVID patients are you seeing this problem in Allahabad?
Yeah, Dr. Swarnakar, first of all, very nice presentation. Congratulations for putting up very nicely and very simply how it goes on till date. What have been the experiences with the COVID fibrosis at all? COVID fibrosis or COVID sequelae, as Dr. Satish has mentioned, this is the right term, and we have seen and we were wondering how it is going on in first week. How can a person develop so much of fibrosis, which we used to say in the IPF with the
Yes.
severe IPF in years, 2 years or 3 years down the line. So that is what it was very much intriguing, and few people we have seen, because we have been only doing post-COVID duties. We have never been into the COVID duties, because we are a private practitioner. So our hospital is only involved for the post-COVID patients, and we have seen all across, from asymptomatics to symptomatics to hypoxemics to severe hypoxemics, and even people have presented to us with pneumothoraces and severe fibrosis on day 10, day 11. They had so much fibrosis, even on simple BiPAP ventilation. They were on only on NIV, and when once they became negative, they came to us, and there was pneumothorax already there. So that is the problem, and this is a huge problem. And yes, you are very right that people cannot give antifibrotics on day 1 or day 3 or day 5. So there has to be a consensus when to start an antifibrotic.
Yeah, so
That is
yeah, yes.
that
So
is
that's the next question. In fact, that actually also
yeah.
Dr. Nitin, any of particular specific high risk group which shows greater propensity for development and or progression of post-COVID fibrosis, in which you would basically like to start early and then you can just pick up these I think high risk groups early. Is there any consensus on that? As of Dr. Ashish was asking, do you have any experience on this? What has been your view on this?
No, I think consensus will emerge only over a period of time. But as you know, everybody has a certain kind of a flair to it. Everybody has experienced enough, and most of the people I talk to, most of the people starting early. How early is debatable. Now, obviously, I mean, if you really look at the RT-PCR's incubation period, it is around 4 to 5 days. So you don't pick it up on day one. The disease per se doesn't get picked up on day one. The first week largely belongs to antiviral. So most probably you're not going to do anything silly during the first week. The beginning of second week, when the COVID pneumonia takes over, COVID pneumonia essentially is not a viral pneumonia, it is going to be a fibrotic process which is progressive. And that happens within a matter of hours to days. So it is generally not weeks, it is hours to days. And that is the time when you start thinking. Now, often you want to give steroids a fair trial before that goes in. And most probably your remdesivir and steroids are going on hand in hand at that time, most of the time. So I calculate day 10 is probably the best time, because by after day 10 there is not much role for remdesivir or a antiviral. You have given steroids and you have seen whether they are working or not and what is happening to them. If at that point in time you have either a radiological evidence of a progressive fibrosis or a clinical sense into it that this person is remaining too hypoxic, is not settling down, a reasonably good dose of steroid has gone in, and you can decide that on day 3, day 4, day 5. I leave it to individual person's choice at that point in time. I usually started beginning of second week, beginning of third week, or the end of first, second week. That is where the antifibrotic gets best trial. I'm sure people will have different experiences depending on the severity of the situation and the progresses. Once in a while, I have seen that the initial disease, initial disease did not have fibrosis at all. But after 2 weeks, patient starts developing a progressive fibrosis. Even that pattern I have seen. So though it is rare, but I've seen a death with that kind of a pattern. That there was no fibrosis, no hint for fibrosis in the first 2 weeks, and it was missed completely by everybody. A little bit of steroids were given, withdrawn, and the patient landed up after 2 weeks, started getting symptoms. By fourth week, she had become too bad. And by the time she reached us, she was on non-invasive ventilation and we could not realistically save her. So even that can happen. So I think you are going to get permutation and combinations of this, but I think possibly end of second week to beginning of third week is the best time window for me, according to my experience.
Now the question was that which are the high risk groups in which you would really think of starting antifibrotic therapy along with anti-inflammatory? Maybe the patients who are who are quite aged, they have got some underlying lung also problem, or some such cohort, Dr. Satish, in which you would like to start this along with anti-inflammatory high risk group that you would identify.
Yeah, I don't think I will, go by groups, Rajesh. And, in your concluding slide, where it is indicated very clearly, you showed about 5 criteria, which I also go by. For example, disproportionate hypoxia, patients on ventilators, severe ARDS, and, the CT scan showing in fibrosis, and subsequent follow-up, which is sometimes very difficult, that there is a progressive disease, very difficult to, find out those kind of, that kind of criteria. So I would use it for any patients where they fall into this group. There is no particular high risk group that I would go on, give it to them very early antifibrotics. For example, those who have IHT, those who have diabetes, have COPD, I won't go. But I will go by these criteria, which are empirical criteria, which, all of us put it saying that, this is the area where, antifibrotics have a role, and these will help patients. So there's no high risk group, but I will use this criteria for my patients.
Dr. Ashish, we
Yeah.
have also markers or also what we call clinical parameters to just identify these COVID patients who would be eligible actually for this anti-fibrotic therapy. I mean, can you just make out by the also clinical, this thing that any of the markers or clinical parameters that you can pick up to identify these patients to start anti-inflammatory with anti-fibrotic?
Yeah, clinically, I think the hypoxemia is this more significant one. If the patient is already on the steroids and still the hypoxemia is increasing, the oxygen demand is increasing, that is the point where we should think of putting the patients on the antifibrotics, number one. Number two, if the patient is having some sort of any fibrotic disease, maybe ILD, maybe post-tubercular, or maybe something like that, which is already predisposed, especially the male patients, then we should always think of putting the patients early on the antifibrotic, because there is no harm in putting the patient on antifibrotic, rather than if we are delaying the initiation and the patient is into the immunodysregulation, then that is the point where we lose the patients. So I would like to share two of my patients who were having these ILD, CTD, and the other one was having IPF, and they were both on. One was on HCQS, and the other was on antifibrotic pirfenidone, and they were all females, and they behaved very well. They both had. One was 60 years of age, the other was 72, and she had been having this fibrotic disease for more than 3 years down the line, but still they fared very well, and the newspapers have published their articles regarding their survival. So coming back to the point that antifibrotics would work very well if we work it out very meticulously. We have to have a suspicion that yes, these are the high risk patients, and they may progress to the fibrotic stage, and that is the point where we should always think of. And I totally agree with Dr. Nitin that 10th day onwards should be the point where if we are thinking of any antifibrotic, we should think of early. After 10 days, it would be better.
And of course, these are the patients who also got high IL-6 and high also CRP. So these are the patients whom we can look with more age, more lung disease. These are the specific groups that
inflammatory markers, especially the IL-6 and the CRP, are very, very important. Even the LDH is also important. If the initial LDH levels are very high and the IL-6 is combined, IL-6 is very high, then these are the potential patients who should be put on antifibrotics early.
Dr. Nitin, coming back to you, is there a role of HRCT in also diagnosis and also picking up this early? It is when it should be performed. Do you really also do this HRCT periodically? Typical pattern that you have seen in your practice, or also follow up that you do on this. So you disclose some background with HRCT business in COVID.
So I think if you start recommending HRCT to everybody across the country, it becomes too much. It becomes too much of a cost. So you have to select your patients whom you are subjecting to HRCT, and most commonly the ones which Ashish and Satish were saying, those which are hypoxic, those who are not settling down, those who are not showing early signs of improvement, which is consistent with say most of the steroid responsive patients. I think these are the patients where the HRCT becomes valuable, particularly when you're not too sure, because you're seeing only a ground glassing like thing on the chest x-ray, and I'm not sure whether the fibrotic process is not documented at all by your x-ray alone, and which is very often. In fact, because the moment you do an HRCT, then you start differentiating between ground glassing, traction bronchiectasis, and early honeycombing, septal thickening. All these are signs which are picked up mainly on HRCT and not on x-ray. So again, doing that just at the process where you are likely to start antifibrotics, just at that time having one CT is helpful. Another thing very important is that the fibrotic change, and particularly the scarring actually continues for a few weeks. So we don't expect immediate resolution of the fibrotic process, though the patient clinically stabilizes. So in fact, I am a COVID survivor, like many of you maybe, and I exactly had the same pattern. That the second week was a ground glass big consolidation. Fourth week was actually a much worsened fibrosis in the same area. It was actually involving much, serpilinear, curvilinear kind of lines which were forming. And sixth week, the whole thing had disappeared. I was not on antifibrotics because the area involved was very small and I never had a hypoxia. That is a different story. But I think what we have to imagine is that radiological lag have to be kept in mind, that we should not be going gung-ho about the idea that clinically patient is improving and the fibrosis seems to be worsening. If you happen to have a fourth week CT for some reason, then you are going to see worsening. And therefore, that is typically the story which I discourage. People typically do a CT at the end of 4 weeks. They come to you with horrible shadows, a clinically stable patient, and everybody wants antifibrotics. And many a times they are not really required because the patient is clinically become much better than what he was on 2 weeks. So that 4 week is a danger time. Then 6 week onwards, things become better. And by 3 months, mostly everybody has resolved. So those who are resolving, they would resolve. So I think that danger period, as I say, where wrong antifibrotic therapy can go on is the fourth week CT. I would encourage it at 2 weeks, beginning of antifibrotics when you are bad. If the patient has improved beyond that point and then don't do a CT early, then do it after 6 weeks. Of course, I mean, I could be wrong by a week or two here and there because everybody will
also invite Dr. Satish to give his comments about his HRCT protocols. Is there any set protocols that we have put that you would do this every about 2 months, 3 months, or something like that for those who are on antifibrotic therapy and those who are not but having post-COVID sequelae?
Okay. Oh, thank you, Rajesh. Very important question to be addressed. Because the pre-COVID era, I would say, we were having so much difficulty getting a CT scan. Saying if patient doesn't improve, then we will advise CT scan. If patient is not responding to the treatment, then we will do CT. But I keep seeing in the first week itself, patients carrying CT scans, twice done already within a matter of 48, 72 hours. And we were also concerned about, the cost involved and radiation and so on. But now, it's done, widely and abused.
And people accept it very easily also.
Most often. I would do it. Yeah. Yeah. So I would do it for, a patient whose PCR is negative. So we feel probably it is due to the technique. And then patient has all the features and I want to pick up, early, and then I would do it. Then after that, probably if patient is hypoxic and then I need some more details about it, I'm not very rigid about it, as Nitin was saying about, the duration and timing. And then if patient is improving, I won't do CT scan at all. And even if patient is hypoxic, we know that there will be some changes. What's happening, Rajesh, is that, those who are not experienced, pardon me for this, not experienced in dealing with pneumonias and this, they are treating CT scan and not the patient. So patient is absolutely fine. His saturation is 97, even post-hoc is probably 96, 95. And then, seeing the CT scan that there are ground glass appearance, there are patch consolidation, and no fever at all. And he's put on steroids, develop complications, sugars are high. So these things are, happening. So I would not ask for a CT scan, unless it is really required, unless it's warranted. And of course, for post-COVID sequelae of the lung, I will do it, as Nitin said, 6 weeks, 8 weeks. There's no point doing and saying that it has not improved. We know that, including NITIN antifibrotics will take some time to act. And in the shown in impulses trial, and you also mentioned about the trials, the ASCENT trial, all this, the FEC, these separates only after some time. So there's no point doing, frequent CTs and saying, oh, it's not improved, and you can't do anything about it. It will improve. And definitely it will improve if patient makes it for third month, fourth month. and we are going to see improvement.
And also
That's my take.
Yeah. And also in that Lung India article, which we had reference to, also they also advised, or they have just opined, in fact, that we can follow these patients who have got this COVID or sequelae for a longer period of time, up to 3 years, and doing, I think, also HSC subsequently every about 6 months or so to, of course, see. So now I think $1 million question. Now you have actually fixed a patient that he should get antifibrotic therapy. You have seen that he is a high risk group. You have seen that he's got raised IL-6, raised CRP, and of course you would like to start anti this inflammatory along with anti-fibrotic, of course, medicine. So which antifibrotic? Of course, you don't have a fixed answer, but still, which antifibrotic among this pirfenidone and also nintedanib you would actually choose, and and why? So I'll start with Ashish.
Yeah, this is a real difficult question to
Yeah.
answer.
So I know,
Yeah,
I know there's no fixed
yeah,
answer. We don't have any evidence, but
yeah,
still, just from your experience, from the data that we have over the
yeah.
pirfenidone and
Y-
nintedanib so far.
you have shown very beautiful slides regarding this, and the answer lies in that only, because we are very much used with the perfenidone, but the only thing is you have to escalate the dose slowly and slowly to build up, and that takes quite a long time. So if you go back to the Zari's Lung India article, which shown so beautifully that there is an increase in the extracellular matrix, and the nintedanib acts better on the extracellular matrix than if you compare head to head with the perfenidone. So going by the theoretical part and by our experience, we should give preference these days to the nintedanib. So I will go by the nintedanib, and because you can right away start with the same dose, you can continue with the same dose. There are less pill burden. There are more better compliance, and we need to see the results, because theoretically the results are better. The exacerbations are less. So I will go with the nintedanib part, and rather than perfenidone.
And Dr. Nitin, your take on this, and then Dr. Satish.
Yeah, I think the large majority of these post-COVID sequelae are being treated by general physicians. And if you have to teach them one single medicine, I'll teach them nintedanib, because in any case they write whatever they write 1 BD only. So if it's Parfenix 200 1 BD, I would prefer nintedanib 150 1 BD. At least they are on the correct medicine in the correct dose for correct time.
Yes.
By the time they come to us and we can take it over. So I think if it is general medicine population choice, undoubtedly nintedanib scores over it because of the correctness of the dosing. That is the first part of it. Now comes they are equal antifibrotics otherwise. So for a pulmonologist, these are equal molecules, but again, makes sense that the onset of action is faster with nintedanib. That's number one.
Yes.
Number two is PFILD, that is progressive fibrosing interstitial lung disease, which is not UIP. The only licensed product is nintedanib. Perfenidone is not licensed for PFID, and this what we are dealing with is surely not UIP IPF, 100%. You call it regressive fibrosis or resolving fibrosis or sequelae or whatever else terminology you use, surely it is not non-UIP. So in the true sense, perfenidone is not even remotely licensed at this point in time. Whereas there is a stretch of imagination for you to take it from PFILD to COVID interstitial lung
We can
disease. So
extrapolate the findings here.
you can extrapolate that. You could imagine, yes, these are similar diseases, at least in the early phase. Later on, they are going to separate completely. No doubt about that. Because most of the world will not be taking it nintedanib in this situation for more than a year. Generally, it will be 3 months to 9 months, not more than that. So I think that's what I am assuming. If small percentage of these people really qualify for a progressive interstitial lung disease, they will continue on it for a longer time. But otherwise, and that has to be meticulously documented and decided. So I think that might be covered in your subsequent questions. So I think that's where I am. So I'm in favor of nintedanib in short.
Is Dr. Satish, because what we are seeing the ground of reality is that we see much more patients, and of course these are not pulmonologists, they're not chest physicians, but these are non-pulmonologists. They would be using this pirfenidone much more often. So hence, of course, we have to just propagate which one is better, in fact. So your take on that, Dr. Satish.
Okay. Rajesh, I think, with all the evidence that we have from the scientific background of treating, other fibrotic diseases, I think nintedanib scores over perfenidine. And Nitin beautifully mentioned 5 points, about the cost. He didn't say about the cost one, but he said about the pill burden, easy to administer, and less side effects. And also because, and as Ashish was mentioning about the DAX and the extracellular matrix, where there's a lot of collagen deposition, which is happening. The triple tyrosinase kinase inhibitors are extremely potent. And quicker in action when compared to perfenidine. I've been involved with the phase 3 trials of nintedanib way back 6 years back for this IPF. So I prefer using nintedanib, less side effects, pill burden is less, easy to use. You don't have to upscale or go on increasing the dose. You start with 150. I don't start with 100, and that's what I would do in this patient. Scientific reason and convenience. The cost, which is a major factor, which used to be a major factor, has come down. I have to bring in the cost here, and it's almost as that. And as you rightly said, and Nitin was also mentioning, many general physicians as treating with perfenidine, probably they know about perfenidine. So when they come to me, what I would do is, probably the dose is corrected for them, saying that this is what is the dose, and if you feel that the dose is, is too high for these patients to take, then I switch over to nintedanib, which I've done in many patients.
Yes, and there was a fear that basically we can give this nintedanib along with concurrently along with anticoagulant or antiplatelet. We have such fear because there was a study which was done and this is quite safe, but still people and also especially physicians say that not to use this concurrently. Concurrently because nintedanib. What is your say, Dr. Nitin?
I haven't found serious problems dealing with concurrent usage of this in clinical experience as well as from the literature. So I don't think there is any real harm. You just have to be sure that you are doing reasonable monitoring of the liver function. And of course, your creatinine clearance has to be known. So if creatinine clearance less than 40 ml per minute, I think the dose comes to 100 ml BID, 100 mg BID. That's the only correction that you have to do. Otherwise, there is no other correction required. And no significant interactions at least have been experienced in clinical practice, and they have also not been documented in the clinical trial. So of course, I mean, we are talking of exotic molecules ranging from dabigatran to rivaroxaban being concurrently used in this kind of a scenario where there is a lot of thrombotic potential and people with D-dimers which are flying into 10,000s and 15,000s or something like that. They will be on some usage of anticoagulants and blood thinners one way or the other. So you have to be careful, but at the same time, I haven't come across major problems in that zone at this moment.
Correct. So of course, from your answers, I see that most of you have chosen what nintedanib. So what is your experience? How many of your patients are there, and how you are aware that their also response? Dr. Satish, and I'll just come to you and then to Ashish and to Nitin. How many of your patients are on nintedanib, and how you are seeing the progress? Are they really also benefiting and they are also getting better, or then we'll have to follow them up for maybe more time and you would need much more time. But then if you see the parameters, or if you're doing 6-month walk test or of some such parameters, do you see improvement?
Yeah. Rajesh, initially, I was not sure about antifibrotics at all because I was, just learning about it, like the whole world was learning about use of antifibrotics. So I never used any antifibrotics very early during the pandemic. And subsequently, and not real data, but the physicians talking about it, using and having a role. Then I started using. I have about 45 patients on nintedanib alone, and some on perfenidine, which have been used, as I said, by general physicians. So I have increased the dose, made that optimal dose, and sent them. So my take on what is the response in the last few months, I'm seeing definitely patients, with a severe disease improving. Very difficult to say that they are improving only because of the antifibrotics. I have also put them on oxygen, put them on anticoagulant, and but no long-term steroids, definitely, and put them on strict pulmonary rehab. And these have helped together, patients are doing well. So I continue to follow them up, and then I'm quite happy with that. And as Nitin said, I haven't found clinically significant drug interaction between anticoagulants that we are using and the antifibrotics. I think it just have to be carefully monitor. So I think if we go by our own personal experience, using strict criteria, that you showed in the slide, I go by that, and I don't just use it for patients whose saturation is more than 95 and they're getting discharged. Never have used, antifibrotics. So I will use it only in those especially disproportionate hypoxemia. And there I found, after a month or two, they're doing well and they're improving and showing, improvement. So also there are combination drugs. So I can't pinpoint and say this particular molecule is helping this particular patient.
Yeah, so careful selection of the patient is of course must. And I would go to Dr. Ashish. How many of patients are you using Nintedanib? Have you been using what is their experience, whether they are getting better or still you are also monitoring them by some parameters like also DLCO or some such test?
Yeah. We have been treating this Nintedanib antifibrotic, and about 20 of my patients are still on the treatment, and they are doing very well. They say that they have felt marked improvement. And of course other medications are also being continued, and even where required, oxygenation is also being part of the treatment protocol. And we have been following them on spirometry and the 6-minute walk test, and they have fared very well, except for few cases where there have been some shortfall and we have to stop the medication. But the monitoring is strict, and it is on the LFTs, and LFTs and KFTs are always monitored, and we are very careful because this is all a new drug, and most of the physicians, they don't have knowledge, and they are not prepared. So sometimes there is questions regarding these usages once the patient moves to them. So that is why
for us using DLC and all this is, I think they will also have some of the results. You got DLCO, and if you can do that, would be also much more.
We have DLCO. We follow them on DLCO, and there's a small improvement in the diffusion capacity. There's not marked improvement, but the patient's clinical betterment is there, definitely.
And quality of life, they say even it also improves the quality of life.
Yes, that is for sure. And
what about you, Dr. Nitin? I mean, do you have any
I think
patients? Have you just put on some patients and are also following them? How has been experienced till now?
I think close to around 100 patients by now. It was, as for everybody else, it was a very twitchy start for using antifibrotics. The first one we started using was Pirfenidone, because Nintedanib was at that point in time 1.5 lakh rupees a month. Now with the price, regulation or whatever it is, getting into the open market scenario, it has become much better. So almost everybody is on Nintedanib now, because of the cost sensibility. And of course the betterment of early onset of action and so many other reasons. But the earlier monitoring was entirely clinical and based on only 6-minute walk or 3-minute walk, or sometimes just bed to chair kind of thing, that kind of a walk. So that much activity and hypoxia we were just monitoring. Our lung function department was practically came to a standstill for a very long time, and now it has restarted very well. Now we are incorporated almost everything, including, for that matter, even last patient I had, we also did an RBTLC, and we realized that yes, there is a genuine fibrotic process and a substantial reduction. So I have seen already a 35% TLC in a documented post-COVID fibrosis in that sense. So as bad as that. And DLCO does tend to improve weekly if you can offer it to them. Our new department is right now undergoing trials. So we are doing it on the sly, so we don't charge the patients. So even without charging, we are able to weekly follow some of our patients, and they are seeing, getting improved. Once again, the credit, I don't know whom to give to, very frankly, because it could be the natural history of disease itself. For all you know, it is just resolving by itself. Then there are steroids. Then there are anti-thrombotic agents which may have an indirect action on the vasculature, and through which it will. And the last part is antifibrotics. So I'm not giving all the credit to Nintedanib or whatever it is I'm using. I think it's a composite, and pulmonary rehabilitation, which Dr. Satish was saying. So it's a composite of all these put together, and you can't realistically say that, okay, this is something which is one single parameter which is working here. But overall, on the whole, people who are surviving seem to be getting better, with or without doctors, and with all, despite all our efforts, they are improving. You can say that.
Correct. So I think even initially we also were quite also reluctant because of the cost, but now the cost is almost like 5 times less or more, I think. And as we have this, I think we can try, but of course we'll have to just carefully monitor them, in fact, whether they're really improving. And of course there are also various factors like also pulmonary rehabilitation, which can play in fact in the improvement. So I'm just picking up one audience, of course, question that I am often seeing on the screen, is that once you have decided to start antifibrotics, patient is there, patient is on oxygen, patient is still having problem. So how long? Because basically when we do ILD, when we treat them for IPF and all, we just ask them to maybe take for years together, maybe for lifetime. So now we don't have any such guidance. So how long basically it can be given? What of course you would step up first? You would first step up steroids, or you would give of course as combination. How long? Which one to be tackled first? What are your views, Dr. Satish? Your wisdom on this? You're on mute. You're on mute, Dr. Satish.
Sorry. A high CRP, and if I find CT scan showing a lot of ground glassing, I would extend steroids, which is well known to have an anti-inflammatory effect and which will work very well. And I know these patients are at risk from getting post-COVID sequelae. So I would that is when I start also the antifibrotic simultaneously, and follow it up, and carefully follow the CRP, and then the clinical parameters, and then start. I'm always thinking about tapering the steroids and stopping the steroids, and then continuing antifibrotics. And so I go by clinical parameter, bio-inflammatory markers, as you were asking about it initially, the CRP levels and ground glassing and those kind of values, and then improvement in saturation, their exercise tolerance, then start tapering the steroids. Also watch for complications of prolonged steroid therapy, and go by it, and allow the nature, and the lung will heal by itself. As Nitin was saying, that we don't know what is working, and ultimately the lung will heal and repair itself. In the end, you just have to support it for the time being.
Ashish, what is your view? I mean, how long and which one to be tapered first? I mean, do you go with Dr. Satish, or do you want that it should be done, should be given just simultaneously for a pretty long period of time, maybe 6 months?
See, antifibrotics are always given as a reduction of steroid. So steroid has to be tapered off, because there are so many complications with the steroid usage in COVID-19. So we have to reduce the steroids, but keeping in mind the most important parameter is the CRP levels. Once the CRP levels are going down, we must taper the steroids, and we can continue with the antifibrotics, maybe 3 months or 6 months. And it has to be carefully monitored on the inflammatory markers plus the HRCT. We have to see what are and the clinical picture has to be always kept in mind before deciding on how much to continue and how long to continue. So, in my view, inflammatory markers plus clinical condition plus supported by the radiological picture has to be there before stopping the anti-fibrotic, and there's no consensus regarding the treatment guidelines, how long
Right.
it has to
We'll
continue.
have to really see that, yes.
Yeah.
And I think we are just running out of time, but one question that I've come from audience is that which of the rehab exercise would you, of course, would you advocate? So, of course, Dr. Nitin, you have also suffered from it, and you had I think, a bit of problem with this thing. So, what you just recommend this? What we are talking about pulmonary rehab, but then is it quite different from what we do, or that you have some special exercise?
I think the simplest exercise that you can rehabilitate yourself as a personal experience from COVID, I can tell you, is walking early and as early as you can. So I was walking through my COVID times 5 kilometers a day, and immediate post-COVID second week I had hit around 10 kilometers a day, and I'm still walking.
How about your cycling? So because I know that you're an avid cyclist. So when did you restore your cycling? I mean, your post-COVID. I mean,
with a mask, it was difficult to cycle.
Because I know that you
the mask and helmet become almost visionless, No, but I have a feeling that it doesn't have to be really upper body like in a COPD where there's essentially a muscle wasting. COVID is not a disease which is a disease of muscle wasting. So I think walking is the simplest and the best kind of rehabilitation activity. And any equivalent of walking, you could pick up static cycling, you can take up bicycling actually on the road, whatever else you can safely do without getting too hypoxic. Is a good exercise. So I mean, it doesn't really matter what kind of a locomotion that you are utilizing, but I think using your legs and getting that, I mean, your
also continue awake
pumps working back to back again.
Yeah. We also continue this awake prone ventilation or spirometry that we see in the prescription.
But very difficult to practice. I preach it to everybody else, but I couldn't practice it myself. The awake prone was not that easy. Of course, it was not needed. I wasn't that desperate, so possibly that was the reason. But I think, but patients do it beautifully. Patients do it beautifully. Doctors probably will not.
So obviously, doctors are worse patients. So there's no wonder about that. Yes, Dr. Satish, do you have some, because specific exercise to inflate the lung or something? Because we do see incentive spirometries in and out, people go for that, and then awake prone ventilation being continued. If suppose he has got oxygen dependence, and if he's going home with oxygenation, do you also advocate this exercise?
Yeah. Okay. So for everyone, incentive spirometry, so that's what I do, because I send them this link, YouTube link, and then to follow that, and then they do it, and then very beautifully shown, demonstrated in YouTube. That is one. And as Nitin said, I say even when they're on home monitoring, home isolation, and keep walking in the room and do simple breathing exercises, and don't be, resting all the time or lying down all the time. That's important. But also, the patients who are hypoxic, who are discharged, they should also start doing some simple exercises and see that they don't become hypoxic or they don't become too tachycardic. And as you know, it's advised that even those who had mild, COVID infection, that you have to do a graded kind of exercise, and and then reach maximum when they can take up those exercises, including training with weights and treadmill and so on, depending on that. And for those who are on ventilator or on NIV, and then their oxygen saturation is low, then I give them our pulmonary rehab home care number, and tell them you get supervised by the proper physiotherapists, and who are all trained, and then they get supervised so that they do properly supervised pulmonary rehab. As Nitin was saying that it's not a COPD where they require training of those muscles, but definitely they'll require, many of them would have lost weight, and their muscle tone would have gone down. So general physiotherapy along with this is required, and supervised for those who are very sick and who are willing to do all this intense pulmonary rehab, home rehab.
So I think we've got enough time, and to have just one last again parting message from all of you about this COVID-19 and its treatment and also fibrosis, which happens. So I'll start with Ashish.
Yeah.
What is your parting
So
message
this
for the audience on this topic of COVID-19 fibrosis and use of antifibrotics?
So this is a disease which is less understood, and more of anxiety into the doctors, into the patients, and about the internet articles which are there. So I think patients have to be monitored clinically. They have to be made more comfortable with the treatment protocols, and they should always be having a psychological feeling that yes, it's not going to harm them. There is good treatment, as well as other techniques which will help them getting back to normal. So no need to worry regarding the treatment protocols and the sequelae and all that, and they'll be back to normal within few weeks.
Is Dr. Nitin?
Yes.
Yes, thank you, Ashish. Dr. Nitin?
I think very well said, Dr. Ashish. I think agree with almost everything. The most important part is coming to a pulmonologist, getting properly evaluated, and then the pulmonologist reassuring them that look, this is likely to reverse very rapidly. I think it goes a great deal in the distance in making these people better. So whether they are on antifibrotic or not, whether they require antifibrotic or not, what dose of steroids, how are you going to taper it, all these are logical questions which a pulmonologist have to tackle. But the patient reaching a properly knowledgeable person is very important. It could be a well-trained physician also who can do this job, but I think most probably the pulmonologists are the best equipped, and I think they, with their knowledge of the background physiology, how it improves, how rehabilitation can be put into practice, all these issues put together, I think, and of course appropriate antibiotic as and when indicated. It will probably not be indicated in 5 out of 10 patients that you are seeing in the evaluation, but still I think that proper evaluation is the best way ahead, best starting point.
Yeah, I think I can't agree more than what I think Nitin and Ashish have said already. But I'm waiting for some good scientific randomized control, where they will tell us, look, this is where it's going to help, and these are patients categories who have done well with antifibrotic, the timing of the antifibrotic, and how long it should be given, those kind of things. I'm really waiting, and also waiting to learn more about the usage and experience from everyone like Nitin, you, and everyone who's participating, Ashish, or any seniors, from their case studies, from their experience, willing to learn about it. As
Nitin, so
yes.
I was telling Nitin at the beginning of the program that I think we should have a good pro-con debate, maybe in some neutral platform.
Yeah.
Where of course we can really fight it out, and we can learn from also various people who have got the experience.
Yes,
absolutely.
absolutely right. And
People with diametrically opposite views are existent even among the
Yes, Nitin, I think you mentioned there's already a discussion going on from the early morning today about is there
webinar, I think so.
Yeah. Is there a fibrosis at all?
At all. I mean, people dare to say that there is no fibrosis.
So I don't know if who's in a cynical view of that, but that maybe we have a cynical view, or they have a cynical view, but that's interesting. And of course, we're all evolving. In fact, we're all evolving, and we would always have a risk and benefit ratio, which of course we'll always see before we really start something. So that would be our basic. And then, of course, that do no harm if you can at least do something good. So that should be the idea. That should be the guidance, with which we should go ahead and updating this thing. That would be the bottom line. So, thank you all. In fact, it was of course quite a stimulating. We have covered almost all the topics that I am seeing in our question panel. So, thank you, Ashish. Thank you, Dr. Satish, and thank you, Dr. Nitin, for sparing your time on this day, it's Sunday. And of course, I just hand it over to again Dr. Sagar.
Thank you, sir. Thank you very much. And I can see that most of our questions from the attendees or the audience have already been covered. Thanks to all 4 of you for taking out time and sharing your insights, sharing your views and practical considerations about managing this disease, and not only in terms of the treatment or a drug or a molecule, but it was I would say a comprehensive discussion right from patient selection, the presentation of the patient, how to monitor that patient once you're giving the drug, which drug to be given, when to give, and how long to continue that drug, and when to taper off the other medication or anti-fibrotic itself. So I would say this was a very comprehensive discussion. Special thanks to our speaker moderator, Dr. Rajesh Swarnakar sir, for that detailed presentation in the beginning, and then for moderating the session so beautifully. And again, special thanks to our panelists, Dr. NITIN Abhyankar, Dr. K.S. Satish, and Dr. Ashish Tandon sir, for taking out your time on a Sunday afternoon and briefing us and answering all our queries. And I hope that with this discussion, all the queries from our audience have already been answered, and we will continue to arrange such meetings so that we can disseminate the scientific evidence that we have regarding different aspects of pulmonology. So with this, now I would hand over session to my dear colleague Sanjay for concluding remarks. Over to you, Sanjay.
Thank you, Dr. Sagar. And indeed, it was a very well organized program. Thank you, Dr. Rajesh, for such a wonderful presentation and the moderation. And thank you to all the panelists, Dr. Ashish, Dr. NITIN, and Dr. Satish sir. Thank you so much. With this, we come to an end of the session. And we look forward to have such a more frequent interaction in the future as well. And looking forward to meet you personally as well, sir, to get some more insights on this.
And thank you, audience, for the viewing. Thank you.
Thank you, everyone.
Thank you.
Thanks, everyone. Thanks, Glenmark. Thank
Stay
you,
safe.
everyone. Yeah, thank you.